Okay, thank you. And I hope everyone had a chance to decompress a little bit and get geared up for the rest of the afternoon. We've got a lot of interesting presentations and some things to approve. So I think we will get back into the DMI, NCHS DMI work, and turn it over to Neil.
Thank you, John. I'll wait for the slides to come up so we're all on the same page. Yeah, I'm Neil Russell. I'm the director of the Research Data Center. And so I have the opportunity to speak to you about a new initiative to make restricted use data available to vetted researchers. Now, historically, restricted use data access has always been through the Research Data Center here at NCHS, going all the way back to 1998. So in terms of moving towards a virtual data enclave, it is a cultural change, and yet it's a necessary step to expand access to a variety of researchers. So the slide that you see here are some challenges that we have faced with the virtual data enclave. So let's kind of go over it quickly, and we'll recapitulate this as we go, as I move through the presentation. Basically, a virtual data enclave does present an increased risk of disclosure of restricted use data when you compare it to a physical data enclave like a research data center. So then we ask the question, do the benefits of having a BDE in the NCHS, do the risks really outweigh the benefits, or do the benefits outweigh the risk? So that could be a potential item for discussion and receipt of feedback. When NCHS was approved to start the virtual data enclave, CDC kind of put a implied demarcation on the number or amount of resources we could throw at this. And so given the resources that we have and the approval that we have, we will initially be only able to stand up 10 virtual machines. From looking at the success of the Census Bureau's remote access system, which has now grown to over 50 projects, we're a bit concerned that demand may exceed supply at some point. And so we asked the question, is the virtual data enclave the future of accessing restricted use data? And if so, should we be planning in the future to expand BDE services? Lastly, for potential discussion and feedback, we don't know what the true operational cost of the BDE is right now. We know what it's taking to kick off the project and to tweak it and modify it for our security risk profiles. We don't have a budget line item for it, so we know that we'll be charging researchers some kind of fees for the use of the BDE. And so a potential discussion point is, should the BDE fee structure be substantially different from what we currently have with the RDC fee structure? So that's a nice introduction to some challenges and so for potential discussion and feedback. Next slide. So just quickly, in terms of accessing NCHS data, you probably all know this already, but through the Evidence Act, it does direct federal statistical agencies to expand access to data through different modes of accessing that data. NCHS has public use files. Those are our open data assets. As Paul mentioned in his presentation, we have CDC Wonder, where you can get vital statistics through a web-based query system that generates tabular data. And then, of course, we have the Research Data Center, which is a physical data enclave for access to restricted use data takes place. And of course, NCHS has a partnership with Census, so our researchers can also go to the FSRDC network. So new to NCHS is the Virtual Data Enclave. Again, it is meant to access restricted use data for vetted researchers and their projects. Next slide. What is a Virtual Data Enclave? Well, basically, it's a researcher logs into a secure remote server and analyzes restricted use data according to their approved proposal in a remote location. So they don't have to travel to a physical data enclave. but they're accessing the restricted use data at some approved offsite location, hopefully closer to where they live and work. And in this case, NCHS will be targeting the user's employer's place of work for doing that access. And I can explain that a little bit more if there's questions about that. But again, the virtual data enclave, just like a physical data enclave, is designed in such a way as to prevent unauthorized disclosures of restricted use data. Next slide. NCHS, and of course, a lot of folks really see a virtual data enclave as having many benefits. Obviously, it helps us to get more in line with the Evidence Act by increasing the number or modes of access to data. Of course, it would achieve that. The interesting thing about a virtual data enclave compared to a physical data enclave is that a VDE could operate almost 24/7. So pandemics, extreme weather, or even civil unrest would not necessarily close down a virtual data enclave, but it would likely close down physical data enclaves like we did see during the pandemic. Nice thing about the VDE too also is that as it operates almost 24/7, researchers can schedule their research and their analyses around their own schedule and not necessarily a physical data enclave schedule, which would, limits them to use, at least for NCHS RDCs, it limits them to business days and business hours. But with a VDE, they could do it any day, all times of the day. A VDE also has the potential to decrease some costs to researchers. For instance, they wouldn't have to travel to a physical data enclave, so reduce travel costs. And if they chose not to go to a census-sponsored FSRDC, obviously they would not have the cost involved in special sworn status background investigation. It's possible that we may see an expansion of the pool of researchers accessing restricted use data because we have a virtual data enclave. For instance, if I'm a researcher in New Mexico and I put in a proposal, I would have to travel to Texas or Utah or California or even Colorado to access the data. But with a VDE, I can stay at my home institution and access the VDE without having to travel those distances. Another benefit that we've identified with the VDE is the fact that our sister agency, NIOSH, National Institute for Occupational Safety and Health, actually already had a VDE up and operational. And having identified that, we felt like the quickest way to get this service out there is to jump on the bandwagon, so to speak, and use the NIOSH VDE enterprise services. Now, obviously, we have to tweak their instance of the VDE for our unique security requirements. But if it's already existing, why not use it? So we're buying VDE services basically from NIOSH. Next slide. Just a real high-level overview of the current project schedule. We received DMI funding in November of 2020. We received CDC approval to start the project in June of 2021. The actual projects kicked off this past September. And recently, Dr. Moyers has approved the VDE for operation, allowing NCHS restricted use data to be within the VDE. Then in July, late July, we have identified some initial CDC-based projects that we will onboard. They'll be our pilot projects, and so that we can learn more about what we don't know about the VDE and its operation, and so we can tweak it so that we are then better prepared to have a more fuller service by the fall of 2022, where we will be then targeting other sets of projects to invite them to onboard with the VDE too as well. Next slide. So let's talk a little bit about the VDE system security. At this point, since the VDE will be operating within NIOSH Enterprise System, NIOSH servers are currently located in the Atlanta data center, which is down in Atlanta headquarters. So initially, that's where the VDE will be spooling up from, is from on-prem servers in Atlanta. NIOSH already has authority to operate at the moderate level, so we don't have to go through a CNA process. Our data, or at least NCHS restricted use data, will be encrypted on rest as they sit on those servers. We will have our own volume, so NCHS data will not be commingled with other data. When the researcher logs into the VDE, it will be through a VPN connection. In other words, the connection between the local machine or the researcher's machine and the secure server will be an encrypted tunnel. So that will be to secure that communication between the computers. The researchers will use two-factor authentication for login. And as we begin to deliver restricted use data to NIOSH for placement on those servers, we will be then having NIOSH employees and contractors become SIPC agents of NCHS. And through the lifespan of the VDE and its operations, if we choose to monitor a particular researcher's activity, we do have logs generated on the system where we can review that activity if needed. Next slide. So when a researcher logs into the VDE, there'll be the usual login screens and so forth, but they will eventually be presented with a Windows desktop environment, which is very familiar to folks. And there will be the standard statistical software already there, SAS, Stata, R, Sudan. But there will be some interesting tweaks that we will have made to the Windows instance on the VDE. They will be prevented from downloading or copying, pasting the actual microdata. That is prevented. There'll be no printing available, no internet access, no email access. Certain Windows programs will be deleted or hidden in such a way that they can't be necessarily accessed. I give some examples there on the slide. But the major issue going on here with the VDE is our ability to monitor researcher behavior in real time as they interact with the data and conduct their analysis. Now, at a physical data enclave, not a big issue because staff are there monitoring that, or if they're in a census-sponsored FSRDC, they're being video monitored. But we can't necessarily do that right now with a virtual data enclave. So as risk of disclosure goes up, we then move the liability for that risk over to the researcher's employer. And so the plan is there will be a data use agreement put into place between NCHS and the researcher's employer. The researcher's employer will sign that data use agreement, acknowledging the researcher's access to the VDE. And that data use agreement will have a lot of specificity in it in terms of do's and don'ts. And that will help us move some of the liability for disclosure over to the researcher's employer. As an example, in the data use agreement, there will be a prohibition on the researcher photographing or transcribing any of the information that is displayed in the VDE when that researcher is logged in. That's one of our greatest concerns in terms of risk of disclosure. The DUA will prevent that, and obviously the employer will know about it in terms of what the prohibitions are. And lastly, what we already do, we will continue to do, is that the researcher will be prevented from downloading the output, but they will notify us that the output is available, and RDC staff will then grab the output, do a disclosure review, and if everything is good to go, then that output will be released to the researcher. Next slide. So I end my presentation where we began, which is talking about the additional risk of a virtual data enclave. I've already mentioned about the DUA will prohibit certain researcher behavior. We also have the issue with, do we need to throw more resources at this? Will the data enclave be so popular that we need to add additional virtual machines? Of course, if we can't initially, the thought would be that we would end up having to schedule researcher use of the virtual machines through a calendaring system and through working with RDC staff to make those appointments. But that's not optimal, obviously. And obviously there's the true operational costs aren't known, as I said before. And lastly, is that RDC staff and researchers will have to learn a new IT system in terms of logging in and navigating the virtual data enclave. So that is basically a thumbnail sketch of the virtual data enclave, and would be happy to field any these questions or receive feedback. John?
Great, thank you. We'll go first with Scott.
Yeah, thank you for your presentation. I'm not really understanding the benefit to the VDE over the RDC. The RDC, as of the pandemic, had gone to a virtual RDC option, so researchers can use it just like a VDE environment. I see from what you're saying, I guess it's when you go to get your project established, you wouldn't have to initially have the physical RDC, and you would have a reduced cost for special sworn status. Is that the benefits to going to VDE rather than virtual RDC?
Well, VDE is a virtual RDC. It's two different titles for the same thing.
Yeah, but what's the benefit of not having it under the umbrella of the FSRDC versus having, if you're both virtual at this point? I could see if they didn't move to a virtual option, then there'd be a huge advantage. I mean, it would be tremendous, but I'm sort of missing some pieces here.
Well, the piece that's missing here is that our current agreement with Census doesn't allow NCHS to use their virtual option at this point. And so we have an agreement with Census, obviously, to use the physical data enclave, but we would need to rewrite the contract, well, the interagency agreement with Census, to allow that potential option. And it's something also we would need to discuss with NCHS management if we wanted to go that way. So the quicker path at this point would be to continue to work with NIOSH to get this system out there. That doesn't mean that we couldn't have two systems, depending on who the users are, but it certainly has been in the back of our minds that there is the potential to use the Census remote access system. Yeah, no, that clears it up. It's feasibility, a lot of it. The other thing is when you go to the RDC, or users, are involved in an RDC project, they have the RDC administrator for support and certain things like disclosure review and things of that nature. So when they operate in the VDE, do they have somebody like an administrator that they can lean on for support in a similar manner? Yes. So the idea would be is that the NCHS RDC staff would be the first level of help desk support. So if it's so we will be going through a process of training RDC staff to be that help desk, and then they can rely on that source too. Perfect. Thank you for the information.
Great. Helen.
Thanks for an interesting and informative presentation. I was going to make exactly the same comment as Scott, which is why aren't you going through the FSRDCs since they have fully set this up already? And I'm not simply saying, oh, I just was going to say the same thing, because I'm not totally satisfied with your answer. It's not obvious to me that it makes sense to build on the NIOSH. It's not as obvious to me that it makes sense for you to build on what NIOSH is doing as it would make sense to go through the FSRDCs, given that you already distribute data through them. And they have a good functioning system. So I would probably spend a little more time, given that this is a relatively long run thing, if it's coming from the Evidence Act, and the sort of expedience of doing the simplest thing may not be, that may be short-sighted. So I would urge you to look a little harder at doing this through the FSRDCs.
Thank you. Noted.
Bradley.
So I'm glad to see it's moving this direction. I have a question about how the relationship with the institutions is going to be established, as well as with the investigators. So does this turn into two different contracts? One institution level agreement with the organization, and then a second use agreement with the investigator?
No, we would fold it all into one.
Is there a reason for doing so? The reason why I'm curious about this is that it could create a little bit of uncertainty within an institution to manage it this way, because what would end up happening is that each time an investigator needs to enter into an agreement, they need to get, they'll have to get some type of new sign off on it. And so it could create like a little bit of confusion within an organization, depending on who's looking at it, because now they have to keep tabs on all the contracts that they've established with CDC at that point. I ask because in another program that we run, we've done it the opposite way, where we do an institution level agreement and then we do one contract per investigator, so that we only have to do it once with the institution. They're aware of what's going on, and then every time the investigator wants to come in, we work with them to address their needs at that point. I was just wondering if there was a particular reason why you wanted institutional sign off each time.
That's an interesting piece of advice. We didn't necessarily think about having like an umbrella agreement with let's say as a university, and then researchers then get appended to that umbrella agreement. It's possible. I don't see any reason why we couldn't do that. Especially, we do have, a lot of researchers from the same institution, so that's possible if we have a number of researchers.
Yeah, I would, if you can, I would encourage thinking about that one a little bit more. I think it could help streamline the efforts for getting people on board, because then you don't have contracting groups trying to look over and potentially negotiate each time they see this agreement.
That's a good suggestion. Thank you.
Great. Andy.
So I guess I was thinking about related things. Have you contacted and gotten feedback from organizations that would fall in that bin, that would be able to support the NCHS VDE link? So one thing that comes to mind is the census RDCs. They're kind of limited because of the difficulty of maintaining them. So my organization, in fact, had started a census RDC a few years ago, and then closer to, I don't know whether it was about 3 or 4 years ago, that was closed. And partly because it is expensive to maintain something like this, especially if it's going to be a staffed RDC. So I wonder whether you've thought about how difficult it would be for the organizations to maintain. So presumably it would be space, it would be a machine that would be dedicated, and the systems would need to abide by all the rules. Whether there are things that could be made more flexible, especially at the user level. So individual researchers being able to implement this. Whether there are aspects like different levels of data that are in the moderate environment that require different levels of security. So some may need all the stringent requirements that you just described, but some may be able to be accessed by the users without all the restrictions on having to use staff machine and space and everything else. So really thinking about making it more flexible for the data users and increase the number of people that could be using it.
Well, right now we're waiting for OMB to release Section 3582 of the Evidence Act, which puts more meat on the bones in terms around tier access and what that would look like, and how an agency may review the data for different levels of security. NCHS data being protected by CIPSE, we're kind of beholden to its guidance, which means that we have to do site inspections of those folks who would be accessing the data. And that's one thing that's not in the slides, is that we would do a site inspection of where the data would be used remotely. It's hard to say what that OMB guidance is going to be on tiered access for Section 3582. So I can't necessarily speak to that right now, but I mean, in general, if there's like a restricted use data file light that we had, Maybe that would be different than just regular restricted use data, but we've not had those discussions. And I wanted to put one thought in from the previous commenter about why don't we just go with census? And if we did that, if we exclusively went with census, then anyone who wants to use the virtual data enclave would have to go through the process of getting special sworn status, which is a cost to the researcher. NCHS can't waive that because they're using a census system. So that might be one sort of downside to going with census exclusively.
Thank you.
And, oh, go ahead, Andy.
Just to add, I mean, that was my question, but my overall comment, at least for the record, is I'm glad that you're doing this, and I'm glad how far you've gotten. And I really look forward to seeing what the current testing comes out with.
Thank you. Appreciate it.
Great. Last question, Joe.
Yeah, I just wanted, I think you know this already, and it's speaks to this issue of your questions about, experiences and, the security with a virtual enclave. But the census has this project with headed by Maggie Levenstein at ISR at the University of Michigan, for this virtual enclave on an experimental basis. I haven't talked to Maggie in a while about this, but my assumption is that there's going to be useful information there for you, even if you choose not to do something through the census RDC, just because they've gathered some useful information in that. And I would suggest that you might want to take a look at that. I don't know whether there's a report yet or not, but I would think it would be informative on the question that you raised.
Thank you. Noted.
Great, Neil. I think that all of us think that this is an amazing development, moving in the right direction. We're glad we have an opportunity to make some comments to help you think through how this can continue to move forward, and appreciate the presentation.
Yeah, thank you for your time.
Thank you. And we'll move on to data query and visualization system with Renee Gindi.
Good afternoon, and thank you so much for having me here today. Just want to confirm that you can see my slides.
Yes, Renee, they're up.
Thank you so much. Well, again, good afternoon. My name is Renee Gindi, and I am here to talk with you about the NCHS Data Query and Visualization System. You heard earlier from Jim Craver about the overall portfolio of DMI projects here at NCHS and the two goals that we have about improving data production and sourcing, and also improving data access. And so this project, along with many others, really falls very squarely into that second overall DMI project goal. And so I'll be talking today a little bit about the development of the project, so the process that we've been taking to get here, some of the interesting partnerships that we've had along the way, a little bit about the where we are currently, so talking about some of our DQS requirements and data decisions, and then talking a little bit about some of our next steps, some of the overall timelines that we'll have going forward. I'll also be asking you for your feedback about, for the most part, priorities. So the DQS group really does have, we have big dreams, we have a lot of content and a lot of different features that we're interested in having be a part of the data query system, but we can't roll everything out at once. And so we're interested in your prioritization about the kinds of data sources as well as features. I'll also be talking a little bit about some of the user groups and feedback that we're trying to get, and would be interested in your suggestions of other user groups where we can promote the use of and get some feedback on some of the earlier products. Now, thinking about that larger goal of improving data access, there are many parts to that. And so one of the sub-goals, the goal that the data query system is really meant to address, is this specific goal of allowing data users to seamlessly connect to data assets with the least amount of required prior knowledge about individual data systems. You heard the words system agnostic, so this is another ability for users to come in and And just to be able to use NCHS data without needing to know quite as much, whether it's about the specific data collection system that collected the data or analyzed them. So for example, if a data user is interested in diabetes statistics and comes to the NCHS website, we'd like to be able to really quickly guide them to diabetes-related mortality from vital statistics and diabetes prevalence or health risk and promotion behaviors from HIS, lab results from Haynes, and then to be able to look at some of the diabetes-related healthcare that they might be receiving through the national healthcare surveys. And we don't only want to be able to guide users to these data. This is obviously something that users can do right now on the NCHS website, but we also want to try to make these data a little bit more interoperable. So in this context, interoperability, I'm using to mean giving users the ability to make some connections, explicit connections between data from the different programs, as well as looking along the end of the spectrum here with related non-NCHS data sources. Now, ideally, we want to do all this for a little bit more of an entry-level user. So in addition to just being able to find these estimates, which is already great, we want them to be able to try to visualize these data on the spot, to be able to spot trends or to spot relationships that they might be interested in. Now, thinking about the building blocks that would therefore be needed to create this kind of data query system, an NCHS data query system really needs to be able to bring together multiple data collection systems on a wide variety of health topics. And when we have those health indicators that are selected, they need to be somewhat harmonized. So they need to either have consistent measurements or statistical methods that are applied and as well as documented. And in cases where they can't be perfectly harmonized or perfectly standardized, some good documentation for users to understand why that might be the case and what those differences might be. And then specifically, NCHS was also interested in giving this particular project to a home with some existing staff resources. And you can see from my slide here that there's obviously a missing piece. And so for that, let's take a brief detour into Health United States and the Health US program. Health US began its life as a congressionally mandated report from the Secretary of Health and Human Services to the President and Congress. And it's been the annual report has been a flagship publication for NCHS since 1974. Now, Health US is, as a program, larger than just its annual report. And the Health US program uses NCHS and non-NCHS data sources to create national level estimates for multiple population groups. Often we are looking at basic demographic groups, socioeconomic characteristics, sometimes even some regional differences. But importantly, as our team presented last January to the BSC, we were engaged for most of 2019 and 2020 in some formative research with data users and other kinds of partners. And ultimately, that has led us to a place of saying that we want to have a more digital first product and a more interactive and customized product redesign. So in January of last year, we actually started talking with DMI leadership to see if Health US actually could be the right place to start some of this work on the data query system. We felt like Health US really met many of the requirements that would be needed to build this kind of system. Health US has historically, again, included data sets that are from NCHS and then outside, from CDC, from HHS, Census, as well as non-governmental sources. Health US certainly covers a wide variety of health topics and has a lot of experience harmonizing within data systems over time. Health US is a trend-focused publication, so we often are looking over multiple years of data collection at a specific indicator. But we also think quite a bit and think very critically about the differences between data systems, especially if we have similar or related indicators. So lots of documentation about our methodology there. And we also have an amazingly talented staff. So that's a great existing staff resource. But importantly, the idea of using Health US as a pilot for the data query system meant that this project could be pretty well bounded in its early phases. So rather than spending time to figure out which indicators and which topics to include and how to measure them, there's an already established set of data tables. So we have the Health US detailed trend tables. These are extensive, very well documented tables that have estimates that are pre-aggregated, so pre-tabulated aggregated estimates. And that can be used as the initial framework. Of course, the intent then would be to continue to add more data sources and more functionality as the program grew. So in the middle of 2021, we actually started to move forward with HealthUS being the initial pilot version of the data query system and using that content to drive the DQS. Now, HealthUS as a program is used to working with plenty of partners to help achieve our goals, whether inside NCHS, CDC, or outside. So we can look at some of the partnerships that we've developed as we are moving through this pilot process. Along with the division directors here at NCHS, we pulled together an advisory group made up of experts from around the center who had lots of experience in data query, data dashboard, and other data management types of activities. And the goals of this particular group were to use their own data query and data dashboard development experiences from around NCHS to help us develop a set of critical features that could be included in a single system moving forward. We will be asking them to provide feedback on the pilot version of the data query system that will use those HealthUS tables, those aggregated pre-tabulated estimates. They have already been helping us develop a scope of work for the current and future DQS contracts, including some of those critical data needs and features that we want to include. And then just making sure that we're thinking ahead. What other innovations could we be building with or on top of that data query system? We also had some enterprise partnerships within CDC during the development of the DQS. We've been partnering with a CDC unit called GRASP, the Geospatial Research Analysis and Services Program Team, and that's a unit within ATSDR. And we worked with them to help award a contract for system development. Now, they have teams of lots of different experts to help us do this work, but probably more importantly, they've been very actively engaged in this kind of data development, data management, data visualization area, taking the lead on projects like the CDC COVID data tracker, which you may have heard of or used, FluView, STD Atlas, the US Cancer Statistics, as well as the CDC's Diabetes Atlas. So it's been great to be able to work with existing CDC partners to help develop those relationships and partnerships. We also wanted to work within an existing agency license with Tyler Technologies, which puts out the software Socrata, which is the platform that is underlying data.cdc.gov. We really wanted to make sure that we were able to work within a CDC environment. This is already a program and a platform that NCHS and other centers are using around CDC to help them manage and store machine-readable files. Again, thinking about those pre-tabulated estimates that users can come in and search for and look for. There are standardized metadata that can help optimize search and organization. Again, very important if we are trying to improve user access overall. The Socrata platform also provides multiple download formats as well as API endpoints, and that's something that we'll talk a little bit more about as we move into some of the data requirements. Now, as Brian mentioned this morning, we also capitalized on a long-standing partnership between NCHS and one of our external partners, Academy Health. That's a nonprofit professional society for health services and health policy researchers. NCHS wanted to think about new ways to expand our relevance and external engagement, and ultimately landed on this data challenge idea to have users come in and visualize some of our data files and see what they could come up with. And this was a wonderful opportunity for our group because this meant that we could be testing the usability of some of these new files, again, taking our HealthUS legacy print files and turning them into machine-readable files, and just see what users can do. What sorts of innovative and interesting things could they actually do with it. The entire process took about 10 months between September when the applications opened, and then the winners were announced, attended the conference, and then actually this past month, we've been debriefing with teams to learn more about their experiences. Now, Brian's already showed you a screenshot of the first prize winner, Sound the Alarm, Large Inequities in Rates of Gun Deaths Among Young People, obviously a very important and relevant topic. Now, what was great about this particular team was that they used those DQS files to, on homicide specifically, to showcase big picture trends by sex and by age group. And then what was also exciting is that they used this as a hypothesis generating tool, as a jumping off point. And then were able to drill down further using CDC Wonder queries of vital statistics microdata. What they did then is use Tableau to construct a narrative, pulling together these multiple visualizations, and something that is very important to the team at NCHS and HealthUS, they made the methods information very easy to find. We joke on our team that Academy Health is the gift that keeps on giving. It was a lot of work in that initial sprint. We had a couple of months to really to develop and refine those processes to transform those legacy print-friendly tables into machine-readable data files. We've really been working to develop the distinct steps in processing and quality control in ways that we had never done before. These were not normally part of our production process. So that was very new, but also very exciting. We also had a chance, as I mentioned, to start following up with some of the contestants and have a chance to hear more from them about the file strengths and weaknesses. We certainly heard overall that they were pretty easy to use. They were able to use those files very quickly to put together their analyses. But there were some places where the contestants themselves were saying, you know, we'd like more cohesion between the data files. Again, thinking back to that interoperability. I want the ability to say, I know that this particular covariate is the same as that particular covariate and that they match up, or that a health indicator matches up across files. We also noticed through the conversations that although we thought we were putting out methodological information in a really accessible and complete way, that perhaps we needed to make that methodological information even more accessible and more explicitly part of those data files that we were putting out. Now, the Academy Health Contest was a development sandbox. It gave us an opportunity to work in a small, defined space, just a few files, just a few clear objectives. But since then, we've taken our experience with that contest and also working with the advisory group to help uncover some key requirements for the DQS system. So the first is that it has to be timely. One of the ways that the DQS can support pandemic or emergency responses going forward is the ability to take new tabulations out through existing channels, make them flexible, make them easy to use. So the idea being that once an analysis here at NCHS is done and checked for scientific accuracy, reliability, we want ways to quickly roll this information out into the public in ways that may fit into existing tabulations, existing visualizations, so that our audience can quickly learn how to use this information. We also thought it would be important, again, thinking about the new Forecasting and Modeling Center, to be able to provide tabulations, especially on trends, in these machine-readable formats. So making sure that we are able to use this as a dissemination tool. We, again, want to leverage this enterprise tools and resources. Don't reinvent the wheel if it already exists. Part of what's appealing about that is we want to provide users with a consistent experience across CDC and NCHS in the ways that they obtain and visualize their data. It makes it easier for people to find what they're looking for and to use what they find. And again, thinking about ways that we can use the DQS and the formats that we're pulling together to encourage more interoperability across NCHS and even some non-NCHS data sources. Finally, one of the things that we were hearing from the user research that we did as part of the Health US redesign is that users really wanted customized interactive data visualization tools, tables, charts, maps. This was something that had to be a really key feature of the work that we were doing as part of the DQS. But also on the other side, from the advisory group, hearing about the kinds of experiences that they were having in the data query data dashboards that they're developing, that there are still some elements where NCHS data really require that additional layer of customization that might not necessarily be available from a more commercial off-the-shelf type of program. The ability to visualize estimates of all different flavors of reliability, whether they're fully reliable or maybe have some degree of unreliability that we need to note for our users. How to deal with rotating content or content that's collected on a data system only periodically. How to indicate visually for our users that there's been a survey redesign or a major standards change like ICD 9 to 10. And then finally, finally, NCHS does, And then finally, NCHS does an excellent job of bringing together many different streams of data, experimental, preliminary, and final data. But thinking about the ways that we can be potentially bringing these together into a single system, how do we indicate that for a user to say that maybe there are some reasons why these data might be updated or might be different? Now, again, working with the advisory group, as well as with our team, we had some formative conversations about the mechanics of the data query system. We made some critical decisions about the kinds of data that the DQS will use, how it will flow, and how our consumers will ultimately access these data. So we'll start at the bottom of the screen here, and we will take a look at the different decisions flowing upwards. So to start off, I have been trying to say multiple times, but we'll articulate explicitly here, the type of data that we are talking about being part of the DQS. These are not microdata files, they're not microdata puffs, they're not microdata in-house. These are the types of data files that you would actually see underlying most of the visualizations that are part of NCHS right now. Aggregated, pre-tabulated estimates, data files that have been checked for scientific accuracy and reliability. These data files are packaged together as data sets along with some standardized metadata to make sure that that data users can easily find what they're looking for, as well as methodological information, and often in the form of footnotes, packaged together by data creators and stewards and uploaded to Socrata, to data.cdc.gov. An important feature of Socrata, of course, is the ability to also federate up to data.hhs.gov, again, increasing the visibility and accessibility of our files. And as I mentioned before, the fact that the Socrata has built into the platform these API endpoints for each data file that we upload allows a custom application, this new software platform that we're developing. The custom application will be able to pull from each of these Socrata API endpoints. And again, we're taking this custom application approach because we want to try to solve some of these articulated issues from around the center, trying to deal with some of the statistical and display challenges that we have. And then, of course, we want these data to be accessible to users of all types. I'm sure that many of you, including myself, have downloaded or looked at data from CDC and other places on our phones over the last couple of years. And so it's very important to be able to get this information out to both desktop and mobile consumers. This is just a mock-up or wireframe of that initial proof of concept application to try to show you some of the facets of the customization that we want to offer to our users. So starting at the top, we want our users to be able to select from a number of different topics, refine to subtopics, and then be able to view the data by those characteristics, again, sociodemographic, socioeconomic, or others. At Health US, we do tend to focus, again, on trend information, so we are very cognizant of being able to select start and end years of the data that are being displayed, but also understanding that certainly there needs to be a single year option. While many of us like to look at our data in charts and visualize it that way, there are plenty of people who also prefer a table, and so we do have that option as well. This slide shows some of the differences, again, starting to get at how we might want to deal with the issues of statistical challenges that are specific to NCHS. Box number 1 is a perfectly reliable data point that absolutely belongs at that line. Box number 2, though, indicates a data point where maybe it has a moderate degree of unreliability, or the complement of that estimate is unreliable. And we want to be able to indicate to our users that there's just something where they might want to pay attention to this particular data point. Box 3 is one potential solution for how we might want to solve dealing with data that are not reliable. Again, thinking about how we want to visualize trends and relationships when data aren't always accessible or available for that particular year. Some things that, again, that are not shown that we're also still interested in looking how to visualize are how to deal with redesigns or changes in data standards. Now, our timelines, all of that is what has been going on prior, and now our timelines have us working towards an internal proof of concept this spring. This will really give our team an opportunity to explore and problem solve and get feedback from lots of key groups, like the advisory group, like NCHS senior staff, as well as scientific leadership. We will then be refining based on this feedback and creating the public pilot version of the data query system with Health US content. And then the idea is that into the future, we would be expanding out that content, bringing in more content from other parts of NCHS and non-NCHS data sources, and thinking about how to harmonize those data across. Right now, the plan has us doing content development and releases kind of on an iterative, in an iterative way. There are many, many people who are involved in this very complex project. And of course, sincerely want to thank everyone on the project team, as well as the project owners and stewards and core support, but of course, our partners around the center and our external partners. So at this point, I'd like to transition back to those feedback, solicitations for feedback, as well as our questions. And I can pause here and look forward to your feedback.
Great, thank you. Feedback from members? So I would say that, this is really good stuff, certainly as reflected. Appreciate the work with Academy Health on getting that feedback. But is there a mechanism for, I'm working in Carbondale, Illinois at SIU, and I'm not involved with Academy Health, and I'm getting on there and I'm trying to figure this out and it just doesn't seem to work. Is there a way to get others to have some input as you're developing this approach?
I would say that is exactly the question that I have for the board. I mean, I think we'd really like to get not just internal feedback, not just scientific leadership feedback. Obviously, those are very important and very critical pieces of feedback that we need. But part of this is it's a system that we are trying to design for users. And it can be challenging to figure out what those user groups are. We are trying to work, one of the projects that you're not seeing talked about today is that's also supported by DMI here at NCHS, is the website redesign. And they're doing a great job really trying to figure out what the user personas are that come to NCHS and are looking for NCHS data. So there is that development of personas that I think is wonderful. We can continue to work with CDC's Office of the OADC, the communications office. But we really, I would really appreciate hearing about other ways that we could be getting feedback, even if it's on preliminary or pilot types of work, because I think ultimately this is a system that is designed to improve access for users. And so it really does need that user feedback.
Kristen.
Hi, thanks for this. It's so exciting to see the plans go into place. When you were showing your visualization, your mock-up visualizations especially, it really made me think of classroom use of these data, partnering with faculty members who may be wanting students to do a data exercise, whether it's in a methods class or I'm in a sociology department, so it's medical sociology class or in a public health school. And I'm wondering if that might be an easy, low bar way of partnering with faculty who could have their students do pilot exercises. That sort of serves two purposes. One is it gets you real-time feedback about the usability of the products that you're putting together, but it also might be a way to partner with faculty about developing resources to put on NCHS's website about how to use these information in classroom settings. And there's a bunch of us here affiliated with universities. We may be able to help provide entry points into those kinds of classes. But it also seems like putting out a call on NCHS's social media, looking for partners for test bed classes could be another way of finding those. But to me, it really screamed classroom use, in addition to all the other wonderful uses. But that was sort of a first thought when I saw your work. And I don't know if that's on your radar, but that's my suggestion.
I think that's a great point. I mean, that was very much that was the target audience for the Academy Health, certainly. And when we had a chance to talk to the students, they talked a little bit about, making sure that those didn't come out, this request for help didn't come out around finals because they were going to be interested during finals. So lots of great things and great ways to tap into the resources that you're offering at BSC. So I think that makes a lot of sense. And actually, when we look at our web survey results to see who is the web surveys of NCHS web users, well, again, of course, at least among respondents, it is very skews very heavily to people who affiliate either as students or teachers. So I think that it's a very natural partnership. So thanks for that suggestion.
And if I could just add on to that, perhaps with discussions of the CDC Foundation, the Beaumont Foundation, or Robert Wood Johnson Foundation, a prize could be on a regular basis, similar to what was done with Academy Health, but for students. Also, there are a number of training programs that the Robert Wood Johnson Foundation has, that scholars and fellows programs that could be a linkage. And if you shoot me an email, I can make some connections for you.
Thanks for the suggestion.
Any other thoughts? Then we'll move on to our last DMI discussion at this meeting. Don't want to preclude future updates because there's a lot of neat stuff going on. We're going to talk about data linkages. I'm going to turn it over to Lisa.
All right. Well, thank you very much. Hello, everybody, and good afternoon. I am really happy to be here today and talk about how the work that we have been doing in the data linkage program at NCHS is supporting many of the data modernization initiative aspects that were talked about first thing this, in the morning. So as I go through this talk, I would definitely welcome input from the board on our methodological approaches in terms of what we're doing with our different projects. And if there's anything else that you may suggest that we should be considering as we keep moving forward with our data integration projects. So next slide, please. So I did want to start just with an overview slide because I am going to talk about several different projects today. So I thought this might be just a good way just to kind of orient the talk, but I will start by just giving a brief background about our linkage program here. I think a lot of people on the board have heard me present previously, but for new members, I just wanted to give an overview of what we do. And then talk about different projects that we are currently engaged in that support the data modernization initiative. So the first one I will talk about is some of the new sources that we are linking to, talk a little bit about evaluating our linkage methodologies and different tools for conducting linkages. And then I'm going to go spend a bit of time talking about privacy preserving techniques. I believe I previously presented about some privacy preserving record linkage that we had been looking into, or PPRL. So I was going to talk about that and some new projects related to that, and then go over some synthetic data that we are working on creating right now. Then I'm going to give a brief summary, and I do have some questions for the board. So I look forward to engaging with you all after I do my presentation. So next slide, please. So just a quick overview of our linkage program at NCHS. So, I think many of you know, right, the NCHS has a lot of survey data. We have our household surveys, we have the healthcare surveys that were presented on earlier. We know that our survey data have these known sampling frames, pretty much the known inference in terms of what they are representing. We collect incredible amounts of data. I mean, hundreds and hundreds of variables on health behaviors, health conditions, socioeconomic status, self-report in terms of healthcare access and utilization. So we have this wealth of information on our survey participants. Most of the household surveys are cross-sectional. So we have this information at one point in time, which has information on exposures and risk factors. But there is this missing piece in terms of outcomes. And so that is really where we have turned to in our linkage program, so that we link our survey data or information that we have on our survey participants to administrative data sources. The sources that we currently link to are on this slide. We link with housing and urban development data to get information on whether or not our survey participants are receiving federal assisted housing. We link with Medicare and Medicaid to get information on healthcare utilization and expenditures. We do link with mortality data to get information on causes of death and time of death. We link with end-stage renal disease. This is a database that has information for the US population for people who have end-stage renal disease. And we also, this is our first time ever linking to the Department of Veterans Affairs, and I'll get into that a bit more on our next slide. So in addition to these administrative sources, we also geocode the addresses of our survey participants so that we can bring in auxiliary information at the geographic level. So it's really, I think what's so exciting about the work that we do is that we really are combining, these exposures and risk factors that are collected as part of the survey with these outcomes in the administrative data source. So when we put them together, we've created this really valuable resource that can be used to answer, many evidence-based policy questions, other, public health research types questions. So I just wanted to kind of set the stage. So that is the main production work that our program is doing and continues to do. And then moving on, so we can go on to the next slide. These are, many of the projects that I'm going to go over now are, these kind of innovative projects that we have been working on in addition to our production schedule. So we are linking to new sources of data. And this is really, ties in very nicely with DMI. We actually did get DMI funding through CDC to link the survey data with Veterans Affairs data. And we are also linking to the Transformed Medicaid Statistical Information System, or TMSIS. And we are one of the first federal agencies to be linking with those data. So, just to kind of give a quick summary, for both of these linkages, we are using enhanced linkage methodologies, which I presented on previously, using both deterministic and probabilistic techniques to really be able to account, for the different types of personally identifiable information that we have on our survey participants. For both of the files, both the VA and TMSIS linked data, we hope to have them available in the next couple months. So we're saying, summer of 2022. And I did just want to note some potential questions or, policy related questions that could be answered once these data are linked. So once we link to the VA data, it's going to be just, I think, one of a kind resource in the sense of having health characteristics and outcomes and healthcare utilization for veterans who were part of our surveys. And we'll be able to, find out information about where they're receiving their care, whether it's within the VA health system or outside. And then in terms of the TMSIS data, I think, given so much that has been happening with expansion with Medicaid, we will have all of these characteristics that are collected as part of the survey, and then finding out about the receipt of Medicaid, and we'll be able to have a sense about timing of when the Medicaid receipt was happening, and having some follow-up information there as well. And one of the things I wanted to note in terms of the TMSIS linkage, we have been working very closely with Arispe on that linkage. I think I mentioned that linkage is actually being funded through the Patient-Centered Outcomes Research Trust Fund. And one of the things, because we are one of the first federal agencies linking to these data, we have written up an outline, really looking at some of the personally identifiable information data quality and how that has affected our linkages and the different variables and the quality measures that we have on them. And it's something we shared with CMS, and they've reviewed it, and it's going to be part of an appendix of our methods and analytic considerations document that can then be utilized, we're hoping, by others who are interested in linking to those data. Okay, next slide, please. So the next project that we are working on, and this is actually part of that umbrella of DMI funding for when we got the funding to do the VA linkage. When we went to the IT Data Governance Board, they had suggested that, once we do the linkage, that we share, whether it's our code or their methodology and how the linkage was conducted. And so for all of our linkages, we do customized approaches. We do all of our programming within SAS, but we do, we like to say we use state-of-the-art methodologies to do the linkages. We've included different machine learning techniques to identify our blocks. We have a paper that was recently published on that, which is very exciting. And so we have, I would say they are somewhat complicated in terms of all of the different SAS programs and, how we go about doing these linkages and all of the technical SAS code. And so, once that was brought up by the ITDG, the Data Governance Board, we started looking into open source software and, to see if this is something that could be shared, enterprise-wide within CDC, so that, that others who were interested in doing linkages, that they could have a quality program that they could use or software that would come up with similar results to what we were getting with our state-of-the-art customized programs. And so we did quite a bit of research, and we came across a statistical, a linkage software called MatchPro, which is put out by NCI, the National Cancer Institute, and NIH. And as we were looking into MatchPro, we saw that it had very similar techniques as the way we were approaching our linkages, incorporating both deterministic and probabilistic techniques, really relying on the Fleege center paradigm of coming up with likelihoods and match weights that could then be used to come up with thresholds and determine who was a likely match and who wasn't. And I think there was also the opportunity to use blocking criteria, which is something that we have found incredibly useful as we're linking to these really large data sources. So if we move on to the next slide, we have begun our exploration into MatchPro as something that we could potentially, share and write up with CDC and the enterprise to have a potential linkage software that, again, perhaps could be hosted on the EDAV server. I know there have been some questions about whether or not SAS would be compatible with that. So I think if you can click again, I might have animated some 2x2 tables for the slide. So we assessed, we considered our link data, we considered that the gold standard, and then we compared it to what the results were with MatchPro. Is there a way to advance the slide a little bit just to show the two? There we go. If you can do it again. We chose a couple thresholds to determine, what was the match acceptance that we would be okay with. And so again, the gold standard, and that is using our customized SAS code to do the linkages, is across the top. And then we compared that with the results from MatchPro. Depending on the threshold that we chose, whether 0.95 or 0.85, we had pretty high concordance, 87% and 89%. Oh, and I should point out, this is just a sample. We used our data linked to the VA as an example, but we were only able to do just a random sample of the number of records. We have run into a few issues with computing and computing resources on our consolidated statistical platform, but that is something we are working on. But I think that is something that definitely happens as you start using, off-the-shelf software. So if you go on to the next slide, one of the next things that we're hoping to do, and again, this is really getting that great feedback that we got from the governance board and really wanting to think sort of CDC wide, we want to do a little bit more digging into the MatchPro software. You can click again. I think there's another animation. I didn't think about that. So we do want to look into a little bit with what might be going on with the off diagonals. We've done a little bit, some very preliminary work into this. We think it might have something to do with how MatchPro handles more common and less common names. Our group has come up with a way of using text comparators for handling rare names and, kind of building off of Jara Winkler and having this conditional approach for figuring out, whether or not a name is matching. And I think there might be some other issues also in terms of zip code, but this is all stuff that we're trying to dig into, and we really do want to write up so that, if people are going to be using this software, they have an understanding, where maybe it's working really well or where they might not have as high quality results. Another thing we would like to do is to look at, the impact on secondary analysis. So let's say you were to use one or the other, does it change your inference? And again, thinking of having users have that information if they're thinking about using this tool. And then again, we do want to still work through a little bit with some of the computing capacity, but I think we're coming up with some techniques. So stay tuned there. Okay, next slide, please. So the next DMI related topic I wanted to talk about were, and I think Dr. Jernigan did bring this up earlier about privacy preserving record linkage. And I actually think it was last May that I did present to the group about some of the work that our team was looking into with PPRL. We actually did get our paper published looking at, again, a similar comparison with what we did with MatchPro, comparing the results that were coming out of using Datavant, the PPRL software that we chose, compared to what we were considering our gold standard or our linkage using clear text matching. Again, with that, we had, pretty good results. We were using the hospital care survey that Carol's group discussed earlier and the linkage to the NDI as our gold standard. And then we ran the same linkage using Datavant and getting the tokens and then figuring out, whether or not we were using just the tokens that were delivered, or we had kind of what we called refined tokens, where we had removed what we knew were false positives. The token set had a high rate of false positives, and then we reran our precision recall estimates. So I did include the DOI. This is published in the Statistical Journal for the International Association of Official Statistics. So next slide, please. So we are hoping to continue. Well, we actually are going to continue. We actually just found out last week that we did receive additional funding through the Office of the Secretary Patient-Centered Outcomes Research Trust Fund to continue this PPRL work. We are hoping to do similar assessments, but expand it beyond the hospital care survey, where we have other, some of our other household survey data, which have more limited PII or personally identifiable information than what we were having with the EHRs from the hospital care survey. We also want to expand the sources that we're using for PPRL. We want to check out some open source software as well, in addition to doing maybe some further research with DataVant. And one of the things, we've been having these conversations with groups across HHS, and one of the groups that I spoke with at NIH was very interested in us doing these assessments and really being able to evaluate at the subpopulation level how well the different linkages were working, or how well the PPRL sources were working compared to when we were doing the clear text matching. Like trying to understand, are we working well with certain age groups or certain race, ethnicity, or are we having some pitfalls depending on the different source that we're using to conduct the linkage? So much of this work, we've been collaborating with Arispe through the PCOR Trust Fund, and I think the idea is that we will be able to produce documents that really will be able to help inform other HHS operating divisions that are considering using PPRL. And then in addition, we have been participating in CDC's PPRL Community of Practice. I recently presented to the group and provided feedback on some standard operating procedures that we are trying to get established at CDC for using PPRL. Okay, next slide, please. So this last area or topic area related to DMI that I wanted to talk about is the synthetic link data project that we have embarked on. Again, this is funded with PCOR Trust Fund funds, and we are really excited about this work. We are piloting methods to create a public use synthetic link data file. So again, this fits in, with DMI, but then also with the Evidence Act in terms of increasing data accessibility while we're really trying to maintain analytic utility of protecting privacy. Our group currently puts out a partially synthetic linked mortality file that actually was recently released last week. But the idea behind this file is that it would be a fully synthetic file where we would be bringing in additional variables from the linked files, rather than just mortality, but bringing in information from our HUD linkage and also from our Medicare linkage. So to start this off, we actually ended up conducting some expert interviews. We interviewed 9 federal partners and 3 non-federal to really get input on what key variables we should consider for the files. Because I think, as many people know, that we can't just throw all of the variables in there. It would really lose analytic utility. So we were pretty much limited to about 20 to 25 variables to put in these files. We have been working very closely on this with the Georgia Tech Research Institute. And we started, we got their name because they actually had done another synthetic data project with other folks at CDC. And it has just been such a wonderful collaboration. They helped lead these interviews with us, but then they are also doing all of this incredible testing and really working on creating these synthetic linked data files that, again, we're hoping will have, some analytic utility and really will help get information out there for users where, we still will have our restricted data available, but the idea here is to have some core sets of variables, some core outcome variables from the linked files that people can work with. And then if they want to dig deeper, they can come into the RDC. So we're proposing that we'll have 3 files. We're using NHIS, the National Health Interview Survey, and then the linked data with HUD and Medicare. We're planning to have 1 file that will have adults 18 and older, and then 1 file limited on 65 and older with a little bit more focus on some of those Medicare variables. And we are also linking with the hospital care survey and planning to put out some variables related to that with HUD and NDI as well. We're hoping for a dissemination of 2023. We've been doing a lot of work also with GTRI and really thinking about the disclosure risk review and developing methods to really come up with a file that, again, kind of repeating myself, but is analytically useful while protecting privacy. So one of the areas, and I do have this in my questions to the board, is that while we're thinking about putting out this synthetic data, we really do want to offer a validation service for users, because we do know that, there is uncertainty in terms of synthetic data. And we want users to have a way that they could validate their estimates, so that if they were going to publish on it, they would have confidence that if they use the synthetic data, that it really was quite, it was looking very similar to the true data that would be through the RDC. So we've done some exploration, actually using some DMI funds. We worked with Travis Hoppy on looking into homomorphic encryption software to see if that could potentially work. And we learned a lot through that exercise. But other things we've thought about is like a manual validation. We know that the Census Bureau has something for their synthetic SIP data where it's actually a server that they interact with. So I think, we're still in the early stages there, and that is definitely a question I have for the board if you have thoughts in terms of validation service. And we also did, I think that feeds nicely off of Renee's presentation and thinking about getting some interactive data tables as well with our linked data, just to make those more accessible for users. So next slide, please. So just a quick summary, and then I will have a slide on some questions that I would like to pose to the board. But I think just kind of a summary of where we are right now. We're really working hard to try to strengthen the exploration of new technologies with data linkage. We are definitely trying to create opportunities to link beyond traditional federal data sources. And I think I actually forgot to say that with the real motivation of why we're looking into PPRL. And the idea really is that we will be able to expand what we link to. So, right now we are working with partners who are okay sharing PII, but I think that does limit the sources we could link to. So that's just kind of tying back to PPRL. But we also, want to expand what we are able to release in data accessibility. So that's really where that synthetic linked data file stuff comes in. And, I think the idea behind all of this, which is really driving so much of the work that we're doing, is really to develop new resources to address emerging public health issues. And I think, a lot of what we are doing is supporting the objectives and the foundations of Evidence Building for Policymaking Act of 2018, and really CDC's, wanting to be able to respond for public health emergencies. So if we transition to the next slide, I did have a few questions for the board. And so I think, we are coming up, kind of tying back to that first bullet I was talking about with these new data sources, the linked VA data and the linked TMSIS. I guess I would love any feedback if you have strategies that you think in terms of outreach to let people know about these new linked files. This is a very much in the weeds question, but we are, as we're working on these synthetic linked data files, one of the things that came up through our interviews is how important bringing in information at the geocoded level. And I think one of the things we've talked about internally is whether or not there are any concerns about synthesizing data that are brought in at a geocoded level when we are working on a person level file. And then my last one, which I highlighted a little bit, is really if you all have any suggestions about a sustainable validation service that we could use once we put out the synthetic data, and having an ability for users to validate their estimates. So with that, I will stop talking and I guess turn it now back to the board. Thank you.
Scott.
Yeah, thank you. This is a great presentation. I had two comments. First, about the verification service. I don't know to what extent the synthetic SIP builds off of this, but they had the synthetic LBD, the Longitudinal Business Database, which was run out of Cornell. And that was John Abott and Lars Vilhuber and Jerry Ryder, I think. And so you might ask them about the synthetic LBD as well. I think they might have morphed it. So maybe this synthetic SIP is like an extension of that, but I haven't followed it, so I'm unsure. The other thing was about the synthetic geographies and generating synthetic data at the geographic level. I still think you could end up with some unintended disclosures from doing that. And so one would want to be very mindful in the way that you do that. Like I've generated synthetic geographies and then had some way of smearing the information so that you would not have disclosures, but that's a little bit different than what you're doing here because you're only partially synthesizing, I'm thinking. So you're at even a higher risk because you can generate synthetic variables that are disclosive to the things that you didn't generate?
So in this file, and that's probably where I was not totally clear, but in this file that we're doing, we are hoping that it would be a fully synthetic. So I think the idea is that we would fully synthesize for this one.
Yeah, I think in this, and I'm not 100% sure on this,
Yeah.
you should check this, but I think just because it's fully synthetic doesn't mean you couldn't have an unintended disclosure.
Exactly.
Because of the fact that when you generate something that might provide information that in the data that, yeah, so I think you could end up with some
I see what you're saying.
problems.
Yes, you're totally right. Thank you. Yeah. And I think we are hoping to reach out to Jerry Ryder and, you know, other folks that had worked with Census.
Yeah, the other name would be Lars Vilhuber.
Okay, I don't.
Lars worked with John About, and he did a lot of that work also. So
okay.
I think his name is on that synthetic LBD, but you might check.
Perfect. Thank you, Scott. That's very helpful.
Lucilla?
Yeah, my question is, first, thanks for doing this. Is great work. In terms of testing that you're really protecting privacy, since we know every time you link to things, the re-identification becomes higher. I just wonder if there is a protocol that's been used for that. And then also for the synthetic data, it has been said that, you know, depending on how you synthesize it, you might or not protect privacy. For us in research, when we're not, you know, we're not public health, there is also the issue of consent to link. You know, I'm not sure if it applies to you or not.
Yes, I did not touch on that. We only link people who have consented. So that I didn't touch on, but it is a great point in terms of the disclosure risk. And we are actually spending quite a bit of time in really trying to figure out how to come up with the right metrics for that. And anything that we would release would have to go through our disclosure review board as well.
Thank you.
Thank you.
So a couple of things. It's almost like you're replicating all the research in my lab.
We know you, Brad. We've been looking at your stuff.
A couple of things. You should, if you're talking to Jerry, you really should talk with him about their experiences in validation. And so one of the things that they saw was that they were trying to figure out how to disclose differentially private results and then try to create confidence intervals about whether or not the result was within the bounds of like the true result.
Yeah.
What Jerry found was that in order to build the confidence intervals, it ate into the privacy budget as well. And so they found out that, you know, every request for some bound on the confidence ended up reducing the amount of fidelity they could answer with future questions. You might want to talk with him about that experience. That's one thing. The other one, you might want to talk to Lynn Pemberty.
We have.
Okay, great, because I can't reveal too much about what NCI is doing with PPRL.
Yes.
But she probably can tell you more.
Yeah, we've been in touch. Yeah, and I think, you know, definitely, and she's aware of the project we're doing and how it's complementing some of.
Great. That's really good.
Thank you. That's very helpful.
Okay, and so then she'll probably put you in contact with other people who are thinking about this. Okay, that's all I wanted to say. Okay, great, good work.
Thanks so much.
Thank you. Molly.
This is really interesting. And one thing I thought about with your question on how to outreach for people to use and test is to really think about some of the policy shops like a KFF, like an Avalier Health, somebody who might be looking to use data in a different way than some of the researchers or the more academic researchers are, because they might be able to test faster and in a very different domain of stuff that they are really looking for and using, and they could be a really great audience for this in the long run, I imagine.
That's great. Thank you. Great idea.
Andy.
That's to be quick. Very interesting as usual, Lisa. Great work. So for the second question, I don't know. I do agree with Scott that even when you synthesize the geographic data, even when aggregated, it could still be disclosing.
Yeah.
You could consider ways of actually having intentionally having diminished models for those variables. So you're essentially inserting even more noise.
Yeah.
The other part for the third question, I thought that was the most intriguing, and I guess I have a question for that one.
Yeah.
So the one use of the validation would be to just for the researcher to be assured that they're not far off the truth, and then quantify that ideally.
Right.
Another use though, and I'm sure very many users would say, well, if you're going to run this, why don't you run these other two tables so that all the runs are on the actual data?
Yeah.
And so I don't know whether you've given thought to that, on whether the validation service would have a component of rerunning user analyses in SAS if an entire program is submitted.
Yeah, I know. I mean, I think that is where we're really struggling. And when we looked into, so we looked into a software that did homomorphic encrypted analysis, and it was really like, you could just, I mean, right now, I don't think they're set up to do models. And so it was just, you know, you could get out basically, is your percentage the same? And, you know, that kind of stuff, but it was very limited. And so I don't know, do we really limit the scope in terms of what could be asked? You know, are you only allowed, you know, you can submit a model and then it's done. And maybe all of the summary information would be in the data visualization tables. You know, I think that's sort of where, you know, we have like about a year and a half to really think through this, but I think that's why it's good to hear the feedback, because I think that's definitely a concern. We don't want to, you know, open it up where people will avoid the RDC because they could just do the validation server and then that's it. Yeah.
So let me just jump in really quick, and I'll be really fast. Is that I think at the end of the day, you need to have a clear adversarial model.
Yeah.
And that will give you better intuition into whether or not there is a disclosure. And you can also assess it on the fly. So it's going to depend on if you're going to support query response or if it's going to just be like a static publication of a result. Static publication of the result, much easier to address than an interactive model. But if you know, it's always difficult to define the adversarial framework. But I think if you're clear upon that and you know who the recipients are and their capabilities, you'll have a better idea of what it is.
Yeah.
If you're when or whether or not you're disclosing.
That's great. Oh, this
Right,
is wonderful.
well,
thank you all.
Thank you so much. Clearly an engaging concept and an important component of how we think about the work. And so we appreciate your presentation. And with that, we're going to move into a break and we will return at 3:30. And for those of you on the committee, feel free to just mute and turn off your camera. It's 3:30.
Irma, are you ready for your slides to be put up?
Yes.
All right.
Great. So now we get into the topic of social determinants of health, or some of us call them the social drivers of health, and activities at HHS related to collection of this data. So I'm going to turn it over to Irma.
Thank you very much. It's great to be here. I started having connectivity problems right at the break. So hopefully, I've joined by phone, so hopefully you'll at least hear me. So I'm going to be presenting an overview of some of the federal activities, some of the activities at the federal, CDC, and NCHS levels related to social determinants of health. If I could have the next slide, that would be great. So across the federal government, federal initiatives are signaling the importance of social determinants of health. Next slide. And so social determinants questions are included in the HHS evidence building plan that was developed in response to the requirements of the Evidence-Based Policymaking Act. And as you can see, it includes program evaluation questions as well as questions related to data development and data policy more broadly. Next slide. So the question that I have for the board is that in light of this focus, I mean, it's clear that social determinants is an important and very broad set of concepts And at NCHS, we address these in many, many ways. And so I'd like to ask your input on how to engage in a focused and strategic way so that our work is most efficient and effective. Next slide. I'm going to start by reviewing some of the HHS activities, beginning with the HHS action plan. And if I could have the next slide. So Arispe has been looking at the issue of social determinants for some time now, and its website is a great place to start in understanding SDOH from a high-level federal vantage point. So there are three pieces that are of this website. The first two relate to the Social Determinants Action Plan, and the third area points to studies and resources. Next slide. So the HHS SDOH Action Plan was released at the end of March, and it's based on a framework of social determinants that were developed under the Healthy People Initiative. And it's a three-pronged strategy that focuses on better data, improving health and social services connections, and what is known as a whole of government set of collaborations. So importantly, this whole of government approach acknowledges that factors both in and outside of HHS contribute to health. Some of the prominent examples are food security, housing, and transportation. Next slide. And can I have one more slide, please? So I'm turning now to the third area of Arispe products, and that relates to resources that Arispe has developed and supported. An important reality of both the HHS strategic and SDOH action plans is a focus on the Medicare program, quite frankly. And this makes sense given the size of this federal investment and congressional interest in patient outcomes and program efficiency. Congress mandated that HHS study the effect of socioeconomic status on quality measures and resource use in the Medicare value-based purchasing program as far back as 2014 or even before that. This report was issued in March 2020, just as the pandemic was getting underway, and it highlighted three questions with a strong SDOH focus, asking about the role that social factors should play in reimbursement, whether the program should collect social risk factors, and whether outcomes would be improved by the integration of health and social factors. Next slide. So that was at the beginning of the pandemic. In March of 2021, Arispe contracted for a study to look at what SDOH data were needed to understand the role of social determinants in light of the pandemic. This report was released in March of 2022, and an important finding was that research on social determinants seems to be limited by lack of standardization, which in turn could serve to inhibit the creation of composite measures, indices, and data linkages. Next slide. Finally, last month, CMS released a proposed rule for inpatient and long-term hospitals, highlighting health equity and social determinants measures. The proposed rule has three health equity related measures in the CMS hospital quality programs, and it also seeks stakeholder input related to documenting social determinants and inpatient claims data. Next slide. So in the development of the HHS action plan, there's a very strong emphasis on the Medicare program. And in looking at that, CDC reviewers observed the need to consider public health. And in order to do that, we established the CDC Cross-Agency Task Force. Next slide. The CDC Task Force initiative is chaired by Karen Hacker, who's the head of the CDC Chronic Disease Center, and it's comprised of members from across CDC. The kickoff was in January of this year, and our early efforts focused on trying to build a framework that could encompass the wide range of CDC's SDOH activities. So it's organized around 6 categories: data and surveillance, evaluation and evidence building, partnerships and collaboration, community engagement, infrastructure and capacity, and policy and law. This big tent recognizes that social determinants is composed of both social and structural factors, each affecting the other, and is closely intertwined with health equity. We did an agency-wide environmental scan and used this information in March for the first of several deep dive reviews for the CDC director. 2 subcommittees, the Subcommittee on Data and Surveillance and the Subcommittee on Community Engagement, participated in the meeting. And a key theme of the Data and Surveillance Subcommittee was the need for standardization of social determinants data items. Next slide. So there's a lot going on at CDC, and one real benefit of working across the agency on SDOH is that we're finding that parts of the agency that don't normally interact are now having to do so. And the two, Dan has mentioned that a little bit in his talk this morning, and I think that, so we're aligning, we're part of the DMI alignment groups, an area that's been very, very new and challenging for some of us is the standards development activities. I know Vital Statistics has been involved in this in a long time, but on the survey side, it is a little bit challenging to think about translating what have been survey items on population surveys into the standards world. Next slide. So now I'd like to turn to the NCHS SDOH related activities. I'm not sure that what I'm seeing is still the last slide, so I'm not sure if I'm having connectivity problems, but I'm on slide 14 of my slides. So this brings us back to SDOH at NCHS. There we go. And this slide that you see here is one that Brian presented at the last BSC meeting. It does a nice job of outlining our key activities that support social determinants of health. We at NCHS contributed to the CDC-wide environmental scan, and these are some of the key areas that relate to SDOH, and there are activities within them. Next slide. So as we took our own inventory, here's one set of activities that we have underway internally to take stock of our own resources. So it's led by our Associate Director of the Sciences Group, and it's an effort to inventory SDOH items in our surveys. And we're doing this for at least two reasons. One, to help NCHS researchers know what is available on all the surveys across NCHS and do more health disparities and social determinants research using our data. And second, to create an at-a-glance summary of relevant variables across NCHS data systems. There are many other such efforts underway. I know of a couple of papers that people are working on and other analytic products that highlight research opportunities using our data system. Next slide. Within my division and across NCHS, we do a lot of work to harmonize measures. We do this by working internally and at the interagency level to identify and assess data sources and measures. The efforts you see here reflect the type of whole of government approach that's called for in the SDOH action plan, as we work with agencies both in and outside the department to find the ideal measures for measuring particular concepts. Next slide. NCHS also contributes to standardization by standardizing measures and by developing data standards. We do this work with agency partners to promote the principles that the government should speak with one voice, that common or comparable estimates should be used whenever possible, particularly in national monitoring efforts, and that national leadership on these data can help standardize the field. Next slide. Actually, before I go to that slide that I see up, I wanted to just mention that earlier, just a few minutes ago, you heard about our data linkage work, which is highlighted both for its methodological contributions as well as the potential it offers to advance data infrastructure in lots of areas, including SDOH. This is an excerpt from the Arispe project that looked at data elements for SDOH, and one of the projects that it highlights as having great potential is the work that Lisa's just talked about. A number of our data linkage projects address areas of interest to the department and CMS. For example, our linkages with Medicare and Medicaid, as well as the project referenced here. I believe this should be my last slide here. So coming back, let's go back one slide, please. And this is the last slide that I'm going to show today. So NCHS is a unique organization. Within one place, you have a cognitive lab that can test and analyze items, surveys that collect SDOH data elements that you can't get in an encounter or that may change over time, electronic health records and vital statistics that were referenced earlier today, and a program that can link person data with social and community factors, program participation, and healthcare claims and outcomes. So this, together with efforts to make these data available while protecting privacy, makes NCHS an important part of the solution to problems of how to understand this broad topic of SDOH using a whole of government approach. while the HHS plan that has a lot of emphasis on standards, this kind of pushes the SDOH discussion into the clinical encounter. And data linkage plays a role, but standardization and data quality issues are going to challenge these efforts in the years to come, and public health is not exactly addressed in the mix. NCHS really has an opportunity here to advance the federal data infrastructure for SDOH and to move between what's becoming beneficiary health and population health. And so we do a lot of things, and we can continue to do a lot of things, but I think a lot of people who are working in this area are concerned that maybe we're not working as efficiently and effectively and as sharply and focused as possible. And so we have a lot to offer, and I'd like to stop here and just really get your views. I know a lot of you have been doing work in the SDOH area, and so we would really appreciate your insights on how to message both the potential of NCHS to really be a test bed for taking SDOH items, putting them into surveys, linking them with other sources, and really using that as a method to understand how social determinants work together with other factors to influence health and health outcomes.
Thank you. Fascinating topic. I can't see the rest of our members. Let me get the gallery view, and I'll start off with David.
Yes, thanks for a really excellent presentation, and it's great to see NCHS doing more in this space. One of my suggestions is do not, there may be some resources that may help you come quickly, and I'm thinking of, there's some recent reports from the National Academy of Sciences on the topic. There is one particularly on, I think it's entitled Capturing Social and Behavioral Measures for the Electronic Medical Record. And it is a 2-volume book. The first one kind of reviews the evidence of which social and behavioral measures have the strongest scientific evidence to attend to. And then the second one focuses on what were the recommendations for the electronic medical record. And one advantage of looking at that list is there was a focus on having very brief measures for the electronic medical record. But some may be briefer than you necessarily want to use in the population health data. But I think it's a good summary, at least I think the report was in 2019, if I remember correctly. But it would be a good summary of what a group of scientists came up with as based on the evidence, which measures are the most appropriate to think of. And that might be one place you could begin and to, not as to begin, but one relevant source of information to consider.
That's excellent. Thank you very much.
Yeah.
Yeah, I have a comment that sort of builds off of what David just suggested. You know, I think, you know, the National Academy, and particularly CNSTAT, does this kind of work on a fairly regular basis, but I think you need something higher level than the kinds of reports that David just suggested. And you really need a strategy and sort of a plan for moving forward in terms of what kinds of work you're going to prioritize and what kinds of work may be less important. I mean, you've got a lot of stuff going on there, and you need to kind of sort through it. And I think a consensus panel would be, you know, ideal for helping you move this ahead.
Other comments? I would just like to pile on to what Matt said, in that there's a lot of discussion, and I think the differentiation between social needs and social determinants in a community and the interplay between those two are a critical aspect of how NCHS and CDC ought to be thinking about these issues. And given that there's a increasing engagement by insurance companies and healthcare providers around looking at social needs, there's really a role to be played by CDC in thinking about how to aggregate the kind of data that's being collected through screening in clinical settings and translating that into the social determinants within the communities in which people live. So I think that this would be a really good topic.
Thank you.
Other comments or questions? If not, thank you so much. I look forward to further discussion and an opportunity to delve into the issues that you raised and that we raised around this absolutely critical area. Thank you. And with that, we will move on to the update. Andy, you guys have been doing a lot of work. Thank you to the work group for coming forward and bringing the materials. Thank you also for your leadership. We have had these materials for a few weeks, so why don't you tell us what your committee or your work group has come up with?
So certainly thank you to this, to our work group that included both BSc members and NCHS members. And they're on the next slide, but before we get into that, so this time we brought this in the previous meeting. This time we're bringing it for a vote by the BSc. And so we're bringing the work group findings and we hope to have a discussion. So setting up the stage at least for what the purpose of this presentation and update is. You've had the materials, you've had the summaries, you've had the meeting summaries, notes, and I'll try and just cover the really high level. So on the BSc side, we have Molly Brody, Ken Copeland, Scott Holland, myself, and then on the NCHS side, Stephen Blumberg, Rebecca Hines, and Jennifer Parker, and Gwen Mustaf that I've left off there. So next slide, please. So as I said, for today's tasks, it's a bit different. It's not just an update. We're bringing this, this is just to jog your memory from what you've had to read. A restatement of the work group charge and summary of activities. It's not a restatement as in a change, it's just a high level reiteration of what Jennifer Parker presented last time on what our work group charge was. To provide the work group findings under the two main questions that were posed to us. And then to discuss the findings and perhaps anything that we're missing. And then to vote on the work group's findings. Next slide, please. Okay, so these are the two general questions that we were charged with. Given the current scientific knowledge, under what conditions would you recommend the use of online panels, surveys for emerging or supplemental topics where gold standard survey data may or may not be available? And then the second question, which is more looking into the future and what may be missing, is what additional research and evaluation is recommended, if any, to increase your confidence in the fitness for use of the estimates from the online panels for these purposes. Next slide. So we had some possible directions indicated from NCHS. It's these five were supplementing online panel with other modes. So given that many of these online panels either have one or at most two modes, or there are other modes that would augment and help. Supplementing one online panel with other online panels. And we have some findings on that topic. Fielding new questions on gold standard surveys to provide better calibration measures. Improvements in statistical approaches to the developing weights. And lastly, communication of data quality for these data is the emitted data where they are relative to core survey data. Next slide. We did have an interaction on setting parameters to specify the scope, because this is overall, it is a very general scope for what we were tasked with discussing. External panel should be used. That is to say, there's no expectation that NCHS will or can develop an internal panel and manage that panel. Survey content will focus on emerging and supplemental topics, as in not those estimates that are currently being produced from the large population surveys. NCHS will retain control over the survey content and collected data, and data will be disseminated through the NCHS Experimental Estimates Program, or whatever name it may take. Next slide. So these slides are one to summarize the meetings that we've had, especially the external meetings that we've had, but also to acknowledge the panelists that devoted their time and attention to present to the work group, the summaries of which you've had. So overall, we had internal meetings both before and after the panel meetings. We had 3 panel meetings with external folks. We had invited people to represent the American Trends panel, the Gallup panel, the Arispe panel, and the Knowledge panel in the first meeting. Next slide. We then had some federal partners with experience either with developing the panels or disseminating the data in particular from panels or similar vehicles, being a household pulse survey. And so from these 2, we met late in January. And then in March, we had another follow-up meeting with yet another panel provider, SSRS, which provide the opinion panel, and the user, the Kaiser Family Foundation. Next slide. So to summarize all those meetings, we provided them with a pretty extensive list of questions that they couldn't foreseeably cover in that limited time. But those were the questions that they could select from and respond to us. And those have informed the questions that we were to address. Overall, under the first question, under what conditions is it feasible and recommended to use an online probability panel for NCHS purposes? We divided that into different sub-questions. One is for cross-sectional estimates. In general, we were in agreement that avoiding estimates that can be reported using the cross-sectional household population surveys that NCHS manages. Estimates from online panels are going to be subjected to a greater risk of bias, and that's suggested by evidence that's in the research literature as well. An added risk to NCHS is the production of alternative estimates that are already being produced and may seem discrepant from another source, such as online panels. And focus on timely estimates for new, emerging, or supplemental topics. This had already been alluded to in the clarification questions that we had with NCHS, and that we certainly reiterate that focus. Estimates of trends is where some of the greatest strengths for probability-based online panels lie. They're well suited for measuring change over time. Some of these panels also offer the possibility of following the same individuals over time, not just repeated cross-sectional administrations of the survey. It requires panel designs that are stable over time. So that may be a strength, but it's also a weakness. Not having control, NCHS not having direct control and not managing their own panel means that they rely on these panels being managed in a consistent, stable manner over time, which then leads to another set of questions that were discussed across these meetings, are methods that the panels use to manage the panels, retiring sample and drawing new refreshment samples, so augmenting the samples over time. And these decisions then matter for NCHS and how the data are being used. Next slide. avoiding estimates that are related. So this was fairly consistent and in full agreement. There are at least two sets that should be avoided. One are variables and estimates that are related to the data collection methods. So if the only mode of data collection is web, for example, then technology use estimates should be avoided and have been found to be biased in terms of who participates in the panels. Similarly, the panels are require a lot of commitment by panel members. They require a lot more effort than a single administration of a survey. So for them to join a panel and to remain in the panel for repeated administrations means that these people are really have high response propensities, high likelihoods to participate in surveys. And so estimates of volunteering and voting, for example, show bias, in particular for probability-based panels. Then avoiding some subgroups and some subdomain estimates. A couple of examples will be estimates for affluent minority bias, minorities, and then acculturation bias. So one example would be African Americans, and within that group, the people that enter the panel, depending on the methods used, maybe the more affluent within that group, yielding biased estimates for a variety of estimates. Similarly, for Hispanics, there may be an acculturation bias in who enters the panel relative to the full population of Hispanics in the population. To pilot new or altered measures prior to implementation. So this wasn't a direct need by NCHS, but we reiterate that this is a good use of online probability panels. Next slide, please. Then to the second question on what additional research, augmenting a panel with other samples. So getting to that question about are there particular subgroups or subdomains that are ill-represented in probability panels, that can be to some degree fixed, but particular measures need to be taken. One of these measures would be augmenting a panel with other samples or administrative data to address undercoverage and non-response. So augmentation with probability-based samples. One aspect of this that the workgroup was in agreement on was that there are different ways to augment the panel, even if a particular subgroup is to be augmented, but those methods should be probability-based to retain the integrity of the inferential mechanism that we use in probability-based surveys. Conduct an evaluation study. So that may require more effort, but would yield more generalizability of the results and better understanding of the quality of the estimates and the properties of the estimates. So for that, it could be a short omnibus survey with NCHS relevant measures and to conduct a multi-panel study with additional cross-sectional arms for comparison. So rather than just drawing one probability-based panel and a single administration of a survey, draw several to capture the variability in the estimates across these panels. So how dependent is the panel design in a particular panel? How dependent are the estimates on that particular panel? In addition to that, methods to evaluate would be to see how the estimates, in particular subdomains, may be improved with kind of an augmentation, a panel plus design, where the panel is augmented, for example, with prepaid cell phone numbers. Another comparison would be if it's desirable to see what the probability-based web panel, what those estimates and how they compare to a low-cost probability-based cross-sectional survey. And that may be an address-based sample, it could be web only, it could be whether male or male. And then lastly, to have a benchmark survey, such as a National Health Interview Survey, which would provide the high response rate survey benchmark for some measures to compare all these different outcomes as a gold standard. Next slide. evaluating different adjustment methods is necessary. And so some of the other recommendations and sources of bias that we've identified also feed into what would be useful to evaluate for these adjustment variables. So in addition to having a rich set of socio-demographic variables, including measures of technology use, particularly in the web-based panels, civic engagement to correct for biases related to the need of having really willing people to join the panel. And then last but not least, health-related measures. That is, measures that would be correlated with the estimates being produced from the panel by NCHS. So these three sets of non-socio-demographic variables should be considered in weighting adjustments. Design auxiliary variables to embed in other survey vehicles or administrative data. So that goes to further that some of these variables that are listed on technology, civic engagement, and health may not be already on existing vehicles. And so variables need to be designed ideally for the purpose of adjusting the probability-based panel estimates and doing that on an ongoing basis. There may need to be periodic evaluation. That is, even doing a study and evaluating how well the panel performs and how different fixes to particular issues and problems on the panel hold may need to be reevaluated over time as characteristics of those who are in the panels change and different design features change. So not treating it as a static evaluation. And then lastly, the communication of data quality for web panel data relative to the core survey data. This topic we did not discuss in the work group, yet it is broad enough that it can probably stand on its own for a work group of its own, especially if it goes into specific measures of how to evaluate data quality. I think that's, next slide. I think we're up to discussion. Any questions for discussion from the board?
So we have time for discussion, just to orient the board to what our task is. After the discussion, we will be looking for a motion to approve the report of the work group. And that would be the written document that we were all provided. Should we approve the report of the work group, we then have to take a vote to make recommendations, which would essentially be the findings of the work group. And these recommendations would then go to NCHS. So with that, I'll open it up for questions, comments as part of the discussion.
And I did not leave an opportunity, and I'm sorry, for anybody in the work group to contribute anything that I may have missed.
I'll get us going, Andy, and just say that this was, I thought, a really thoughtful report. I was able to participate in the first discussion on the panels, and it certainly gets to the issues. As much of the discussions that we've had, how do we get the kind of information that's needed for policy and assessment of the health status of our country in an environment which many researchers have identified and run into, where people are not picking up their phone, are not participating in surveys. So as a complementary tool, I think that your work group has given us a lot of insight that would be worthy to share with the National Center about how to proceed in exploring this particular tool as an adjunct to the work that they're already doing. So thank you. Other questions or comments? Hearing none, would someone like to make a motion to approve the report of the work group?
I'll make that motion, and thank you to the work group for such a nice, thorough and informative job summarizing this topic.